Welcome back. We have 3 people who have signed up to give a public comment. I will announce your name and your organization, and our moderator will unmute you so that you can speak. First, we have Tom Merrill, who is a principal at Redstone. Please go ahead, Tom.
Good afternoon. How's my audio? Can you hear me?
Yes, we can hear you.
Okay, great. So yes, this is Tom Merrill, principal at Redstone. Real briefly, we're a research and advisory firm that supports organizations in their value-based care strategy work. Very supportive of this committee's work. We do our best to encourage our private sector clients to take advantage of the great thinking that's been produced here. Relative to the comment we'd like to make, I apologize if you covered this yesterday, but I was on early and then got called away. Eager to go back and review, but if you did cover this already, just take this as support that you're exploring the right things. We at Redstone would love to see specialty population models developed around specifically high cost, high needs populations that can be defined by non-medical factors, for example, social determinants of health. We think the multi-visit patient work done up in Massachusetts and New York State and the district programs could be instructive here. Plenty has been published on that front. Relatedly, and with the private sector in mind, we'd love to see this group explore the misalignment between more preventive health-oriented care models and the limited annual timelines of most insurance benefits design. We know this isn't a problem in Medicare per se, but clearly this prevents a huge portion of U.S. healthcare finance from being able to justify payment for services that often, don't bear fruit until years later when a member is likely with another insurance company. So we believe that this could probably involve more payment for measurable health improvements rather than simply relying on cost savings that may accrue years later. So anyway, that's our comment. And again, we love your work and appreciate the time and the opportunity to comment.
Thank you so much, Tom. We really appreciate your presentation. Next up is Jennifer Gasparini, the Director of Regulatory and Quality Affairs at the National Association of ACOs. Please go ahead, Jennifer.
Hi, good afternoon. Thank you. NACOS appreciates PTAC's focus on this issue and the coordination with the Innovation Center's work on specialty engagement. NACOS and ACOs share the commitment to the administration's goal of having all Medicare patients and most Medicaid patients in an accountable care relationship responsible for total cost of care and quality by 2030. And to achieve this goal, we must focus on allowing providers to coordinate care across the continuum of care, working together to achieve optimal patient outcomes. This includes engaging specialists in total cost of care models like ACO models. After more than 10 years of payment model design innovation, we've learned that having mandatory specialty-focused bundled payment programs and primary care-focused total cost of care models can lead to overlap challenges that can create provider and patient confusion and administrative burden. Designing specialty payment approaches within a total cost of care arrangement can create the proper incentives to encourage coordinated care across the care continuum. To support ACOs in this work, there must be more data transparency to give ACOs and specialists access to quality and cost data to inform referrals to high-value specialists and create financial arrangements and incentives that encourage this coordination. There must be flexibility to allow ACOs, plans, and other entities to design approaches that are best for their population. However, lack of standardization will ultimately lead to more provider burden as well, so approaches should allow for options from a menu set of more standardized approaches that allow a level of flexibility. For example, defining industry standard definitions for episodes. Finally, ACOs engaging specialists in shadow or nested bundles are often faced with challenges regarding small numbers, and sample size is critical for accurate measurement. So performance data must be based on a sufficient volume of cases, even if we have to look across payers, so that spending estimates are statistically reliable. ACOs are very interested in finding ways to further engage specialists in total cost of care models, and providing more data, both episode cost data and quality data, to ACOs will help support this work, whether it's supporting referrals to high-value specialists or subcontracting financial arrangements like gain sharing in an ACO. ACOs are not all the same, and flexibility must be provided to ensure ACOs are meeting their patient needs. For example, a rural ACO may have less referral options, so engaging specialists may look different for that ACO in that particular market or region. We look forward to continuing to work with the Innovation Center, CMS, and ACOs on this issue to find ways to meaningfully engage specialists in total cost of care models. And we thank PTAC for their attention to this issue.
Thank you so much, Jennifer. We appreciate your comments. Next up, we have Amita Rastogi, independent consultant, industry expert in value-based payment. Amita, please go ahead.
I lost volume. Can you hear me?
We can hear you. Please go ahead.
Oh, good. Okay. I'm Dr. Amita Rastogi. I'm currently an independent consultant in value-based care. I was the chief architect of Prometheus Payment in the episodes of care space. As a cardiothoracic surgeon trained at the Mayo Clinic and with a master's in health administration degree from the Martin School of Public Policy and with a master's in biostatistics and epidemiology from the University of Chicago, I bring clinical, business, and analytical skills to the table. Moving from volume to value requires a simple mind shift. For providers such as myself, we have to think, is this procedure appropriate for the patient? Is this service really required? Is this referral truly necessary? Will it improve outcomes for my patient? By making specialists accountable for total cost of care arrangements, they become part of the value-based movement. Building on the CMS programs, such as for kidney care, where nephrologists are made accountable for the total cost of care for kidney patients, we are already seeing this mind shift happening with the specialists in the real world, such as in my husband's 11 nephrology group practice, which are adopting the CKCC model. Nephrologists are watching every lab test being done, every procedure that is being ordered. Similarly, we can make cardiologists, orthopedic surgeons, GI physicians, and other specialists as the quarterback for patients with complex needs in a total cost of care arrangement, with primary care physicians still being part of the team. Using a nested design, every inappropriate procedure or referral they avoid would go towards their shared savings, much like Dr. Kevin Bozick highlighted earlier today. For example, cardiologists could team up with cardiac surgeons in total cost of care arrangements for a cardiology cluster. As is happening in the nephrology world, kidney transplant surgeons are reaching out to nephrologists to be part of their kidney care team. This is happening, and I'm seeing it real time. So the tables are turning, and the true value-based movement has begun. Organically grown systems and accountable arrangements avoid biases and with the system from being too prescriptive. It is the willingness of providers to change their mindset that will truly drive the shift to value, and it is happening. And once they take accountability for whole person care, being responsible both for clinical as well as financial outcomes, we see true value-based movements come in. Thank you.
Thank you so much, Dr. Rastogi. We really appreciate your comments. Amy, are there any other public commenters that have signed up? All right. Hearing none, that is the end of public comments. Now, the committee members and I are going to discuss what we've learned yesterday and today from our guest presenters, the roundtable discussion, the background materials, and the discussions. PTAC will submit a report to the Secretary of HHS that includes our findings from this public meeting, in addition to what we want to highlight from yesterday and today. Similar to yesterday, we will start with time to reflect more generally before staff continue with the slides identifying potential comments. Members, you have a document on potential topics for deliberation tucked into your binder to help guide the conversation. To indicate that you have a comment or question, please flip your name tent. I know we have a lot of great insights from the last 2 days. It's been really rich discussion. So who would like to begin? Jen.
Well, yesterday I had 10 comments. Today I have 5. In no specific order. The first thing that we heard about a few times is that specialists, quote, just want better care coordination as a desired outcome. But when I heard those comments and in the context of that conversation, it made me wonder, were they really saying they wanted to stay in fee-for-service with no risk? I think our discussion over the last 2 days has highlighted why the incentives are not aligned in the current system to make specialists want to participate. And I hope that some of the things that we were able to highlight today have demonstrated what those incentives need to be or could be, even if they're not financial. Number 2, what I heard was that we probably are using the wrong language and rubric. When we say primary care and specialists, we are disadvantaging both groups. Not all primary care services are the same and not all specialist services are the same. And what I heard was, and not to be too simplistic, but what I heard was that maybe a disease-based care model might be the right approach. I do think our PCDT team framework that we recommended in the beginning as a straw person got it right, and that looking at both cost and utilization factors are potentially a way to start thinking about how to identify these disease-based care models where there's potentially avoidable cost in the system. Now, one caveat to that is that that potentially avoidable cost is based on a fee-for-service chassis. So there may already be inequities within the system, but that is the simplest way for us to start thinking about it. The next thing I heard is that PROs can be a really important component. I think we all know that, but it's around how do we actually implement those how to identify those outcomes that are important and then include them as one of those incentives that I talked about in my first comment, because those are actually a really strong driver. And although collecting the information is not free, the opinions of our patients is really important and it's free. Number 4, I heard what I liked in Dr. Zerzin's presentation about what Washington State has done. It really summarized what I think we heard throughout the 2 days, and that's practice transformation can happen. We have lots of examples of that in various sectors, but it's expensive and it requires upfront funding, a prospective payment. And I think there's some things there that she described around doing practice assessments and identifying readiness, and then thinking about a model to help nudge groups to move to the next level. But what I thought she said that was really important is that there's also an expectation. So it doesn't sit in pilot phase forever. It then pivots, and that's explicit from the beginning about what that expectation is. But I think there's really something interesting there about creating practice transformation with prospective payments. But what I'll note is that I think that requires interagency collaboration to fund. And although that may be challenging from a policy or regulatory perspective, I think if our country wants to move forward into true value-based care, we have to do that. And then last, I'd comment that in the most recent presentation about the musculoskeletal model, what I thought was interesting was that with the right incentives, with various collaborators, there is healthy competition about who should be the attributable owner of a patient. And no pun intended, I think that healthy tension and competition is a good one for Medicare beneficiaries and for patients. So I think models like that make care teams want to be responsible for care for a patient, regardless of what the subspecialty training is of those groups. Those are the right kind of care models that we should be thinking about and then trying to create financial incentives for them. Thank you.
Excellent. Thank you so much, Jen. Who would like to go next?
I don't think there's much to add to that, to be quite honest, but I just wanted to emphasize that we heard, in addition to what we heard yesterday, we continue to hear today how clinical practice is now continuous, and that we shouldn't think of it in buckets or silos, but rather a disease process across an entire continuum. And therefore, that dictates what our payment policies need to be, what our clinical models need to be, what our team structures need to be, and clearly help in getting the system teams that are capable of working across multiple specialties, including primary care in general and specialty care. And also we heard again today how lacking, unless you're part of a big system, how lacking crucial data is in terms of truly being able to manage patients across multiple specialties. So.
Excellent. Thank you, Angelo. Josh?
Yeah, I agree. I think agree with many of the comments that have been said, but I think my overarching reaction is that assuming adequacy of workforce, which is an assumption, is not always true in some areas, but assuming that one of the key takeaways for me is that I think a lot of this begins with capacity assessment. And that really stuck with me from today. I think a lot of the things we heard these last 2 days about what works and what doesn't work can be tied pretty directly back to that. Expectations, loss of communication, what the goals are for the clinicians and the patients involved. And so I really like that idea of making that assessment of, in one session we heard about what's advanced primary care or maybe more intermediate, but I think can be applied more broadly. What I liked about that example too is there were separate but complementary assessments for primary care and in that case behavioral health practices, but you can imagine analogs for other subspecialty practices as well. And I think that also, I think the reason that's so important to me is that then it emphasizes the other things we've heard over the last 2 days, which is that if you want to integrate, it might be through acute episodes or procedures or conditions, one condition, multiple conditions. And so it's not all or nothing. As I mentioned yesterday, I think it very much is, there are many choices there. And I don't know a better way to assess those choices unless we understand those groups or those clinicians that we want to integrate into these models and engage, what is their capacity for integration? And so I think that's very important. I also agree with Angelo. I think care is increasingly continuous, and yet under the aegis of payment models, accountable entities are pretty discrete, right? And so that again underscores the point about capacity. So even if we think about this continuum of care, one large group, a collection of smaller groups, these clinicians and those clinicians are going to take accountability and integrate with that other group. And that discreteness to me, again, underscores it's really important to understand screening, referral, QI, ongoing care management, workforce, physician, non-physician. Those things I think are really integral. And finally, I'll say, when I think about how that can be applied to payment models, I could imagine at least two potential approaches. One would be that in that assessment, we identify when and where certain payment models and certain incentives, many of which we've talked about at this meeting, would be more likely to work and create less inappropriate abrasion on clinicians and practices. And on the other end, we can then better learn from models that are ongoing now or that have completed about, why are we hearing in the field these things aren't working? And so I think that capacity assessment gives us a new lens into that.
Excellent. Larry.
Well, I have several, but some of them may be replicative of what we've just heard. But I came away with the number one conclusion that, as we have learned before, risk should be borne at the level of the entity. and incentives need to be deployed at the level of the provider. But this implies, on the basis of what we've heard, that all providers need to be either employed or tightly contracted by a risk-bearing entity. Our focus should be on patients and their diseases rather than providers in their chosen field of practice. Providers may be better categorized, therefore, not by their specialty, but by their main function within their specialty: screening, acute care, chronic longitudinal care. And then we can build complex patient attribution models to be deployed based upon the patient needs and the provider function and how those two can be brought together. Finally, payment models would then need to be deployed based upon this function: bundles for acute care, per month payments for chronic longitudinal care, regardless of the provider specialty, but totally consistent with who's bearing the responsibility for the care.
Thank you, Larry. Jim?
Thank you. I'm just going to try to add what's not been said. After the capacity assessment, it seems that what we heard was capacity building is somewhat organic at the medical neighborhood level, and that one of the strategic opportunities that sits in front of the country is to, kind of like what Walter was alluding to yesterday afternoon, was keep it simple and then get out of the way, right? And then I think we just heard from NACO that moving the funds to the accountable entity, but having some requirement that the accountable entity enable the development of capacity building within entities that are really wanting to create the medical neighborhood. So there's some prescriptive opportunities. We need the medical neighborhood with accountability that's digitized and connected, and telehealth and all the things that can work, but let the money be front-ended so that capacity building is done differently in Houston than in Central Texas, than Dallas or in Minnesota. And so the other thing I wanted to say is I think that when we talk about value providers, whether that's a specialist today, some primary care doctors that are in value-based work for the last 4 or 5 years, nursing homes or skilled nursing facilities, I think it's incumbent upon us to recognize it's kind of like a time zero for them. That integration really hasn't happened and value-based work hasn't started. And if we go back and think about what it was like when primary care doctors first started to think about value-based work, when ACOs first came about, they were at time zero. And so I've watched quality metrics inside the ACO, primary care ACO organization, improve significantly. Certainly not at goal yet, but getting better. And so I know that if we were measuring primary care doctors at time zero and saying they're not value, so we're not going to give them a contract, that would have been a huge mistake. Further, that just erodes the sense of professional dynamism that's inside medicine, that will kind of create the competitive juices, the competitive forces, I think, that Josh was bringing about, that will cause improvement in quality and cost control if we just assume that we're still pretty early in the game and that lots of specialties and lots of organizations that are along the continuum of care haven't really engaged this yet. So we really don't know how valuable they're going to actually be until we actually bring them into a neighborhood that's connected to primary care doctors who have attributed patients who've got to get the job done and create equity and reduce disparities. So I'm hopeful that with CMMI's goal that we can continue to advise to take everybody at a time zero and build capacity, but front load the funds so that that capacity can be built and try to stay out of the way, not create more complexity, I think is, so we've got to sort through that.
Thank you, Jim. Audrey.
So just wanted to ask you all, given that in this meeting we've been talking about having payment for people that are providing chronic, disease management separate from payment for people who are doing procedures or acute episodes. Are there any concerns about the potential for underutilization, stenting on care, issues around disparities for certain patients if specialists are getting kind of this payment, not based on fee-for-service and, actually seeing the patients? Does the committee have concerns about that? And are there, performance metrics or other opportunities to guard against that?
I'll jump in on that. I thought that one of the comments, and I think Jen brought it up, which is this idea that was introduced today around the self-reported health status starts to address that concern, right? That the consumer ultimately, or the collection of consumers within an ACO in the aggregate could actually start to express whether or not, in fact, there was an unintended consequence of rationing, which then leads to poor health and greater disparities. I also thought that, and we see this in REACH, which is that there's this equity improvement plan requirement. So there's not only, and inside that plan, there's this idea that you have to pick a goal and actually demonstrate movement of that goal. Being accountable for moving it seems to be a way to kind of build in, or is already built into some of the ideas to kind of help protect against, I would call the rationing approach of reducing care delivery for the sake of cost control. So I think in both of those ends, having an equity plan and execution and strong equity reports, requirements, and let the market solve for that, I think is going to protect the consumer. But more valuably than that would be the consumer themselves, talking about in particular conditions, whether or not they are actually relieved of their pain, their functional status is better, and they're satisfied with the care they've received.
Yeah, maybe I'll just add to that too. I mean, I think, how do I say this? I think one of the concerns I would have is that we take history and carry it forward as the rule, like an example from history, and carry it forward. So I don't think many, if any of us, would argue that bundle payments by volume and experience has really been an orthopedic procedure experiment in a formal way. And yet there are many different types of what's another word, since bundles is not a good one, but there are other bundle-like things that can happen. I think episode-based cost measures, a lot of things that we're seeing are moving us away from that, and I would really encourage us to think outside that in a bigger frame, in part, Audrey, because I worry about potential under-provision, and I'll come back to that. And what I mean is that there was a comment today made that epidemiologically, you're not worried so much about the efficiency of the episode, you're worried about whether a person gets a procedure. And I would admit, for something that's relatively preference sensitive and high volume and common, like joint replacement, that's arguable. There are many other episodes, like acute exacerbations of medical disease, where that's not actually true, I would say. It's a different epidemiological process. And so I just want to make sure we shake free of history, which teaches us a lot, but we can rethink episodes and conditions and bundles in a different way. And I think it's particularly important, Audrey, because of what you said, which is that I think implicit to this idea of cost efficiency is a implicit assumption that that in many cases less is better. And I think given the huge inequities in this country, I think that's not always true. And I think sometimes what's right and what's equitable needs to be more. And so I would hope that we take that wider aperture when we think about these topics. And just to take that analogy that I mentioned of joint replacement, we know, dating back unfortunately many decades, that receipt of joint replacement where they go after the surgery, the types of post-acute care are highly disparate by income and by race. So how do we deal with that? I certainly don't have the answers, but I think the idea that we would just say, let's just nest and design and risk adjust and be more cost efficient, I don't want that piece to be lost. So I really appreciate you bringing that up, because I do think sometimes we probably want more of guideline concordant high quality care, and I hope our models can reflect that.
And Larry.
I just wanted to address what Audrey just asked. What I heard from McClellan, DeBrantis, and Jones today was not a standard PMPM payment, but a PMPM payment for the cognitive, risk-based, responsibility-taking components of medical care, but then a markedly discounted payment for those procedures that have to be performed. Audrey, I'm going to flip what you just asked us with a different type of example. And I'll go back to the gastroenterology space again. You have gastroenterologists today that are in their ASCs doing colonoscopy on inflammatory bowel disease patients and having the cognitive work being done by a APP in the office. Whereas when you really think about it, in a repetitive procedure like a scope, that probably could be performed by an APP, but the person who went to school till they were 32 years old to master the knowledge of how to take care of that ill patient should be the one making the decision. So, I think taking some of the money and appropriating it for the cognitive services of specialists that have been actually undercompensated, and to pay that, you take money from the procedural services. Somewhere there may be a sweet point, a sweet spot there, so that we encourage the cognitive services from our specialists, but at the same time make sure that the procedures are still being done, but the procedures don't become the main source of revenue for the specialist.
I'll just add a couple things. I think that's a really important question, Audrey. One of the things I heard, and we've heard in other sessions as well, is the movement towards disaggregating data by race, ethnicity, and other components, and utilizing that as a quality metric that's critical in looking at outcomes and really understanding. And then I heard a whole theme in this session about the emergence of technology in different ways that I think bridge disparities. So the ability to do e-consults, telehealth, wearables in the home, things that address some of the barriers related to transportation, hours of availability to get to offices, access issues that make things more possible. And then an underwriting theme that I heard about success in any of these payment models is the need for longitudinal relationship and trust, and also the integration of interprofessional teams, other disciplines, and trusted providers, which may be a community health worker, a nurse, a social worker who's following longitudinally over time. I think those types of models have a lot of promise for addressing the barriers of trust and access. And some of the data discussions around proactively seeking populations who are not accessing care, I think has promise for being standard, and how we're looking not only at high utilization, but no utilization is just as important of an indicator. And then the themes that also came out is the importance of anticipatory symptom management, anticipatory disease management, and proactively addressing social determinants of health and health-related social needs in populations. Those things will start to drive care reaching out to clients rather than waiting for clients or patients to crash and go into crisis before care is delivered. I think all of those things are really critical for underserved populations. Any other comments?
So again, just in terms of process measures, for example, if a patient is attributed to a certain provider or a certain care team and they have a certain condition, and the care team has not had any visits with that patient, say, within a reasonable amount of time? Like, is it possible to build those things in relating to accountability?
I think that's critical. And having worked in hospice care, which kind of is a total cost of care model, you're completely driven by preventing crisis. So the team interaction with a client is based on proactively reaching out, proactively visiting, proactively engaging, because the payment model is such that you want to prevent crisis and manage it responsibly. So it changes your interaction. Walter.
So it's been a really productive 2 days. I want to thank the PCDT again for lining up some great speakers along with the PTAC and NORC staff. I won't repeat a lot of the comments that have been already stated, which I largely agree with. A couple additional thoughts, though. I think one of the things that stuck out to me from our 2 days is the current risk models, the current pilots don't really do a good job of somehow taking into account preference-sensitive care. So they don't reward providers for preventing something that is going to require more care down the line, care that doesn't happen, right? So I always got to go back to kind of chronic kidney disease, and the nephrologist who prevents stage 3 chronic kidney disease from progressing to dialysis doesn't get rewarded for that, right? The many years of payment that CMS would have had to pay for the dialysis care is not seen. There's no value to that nephrologist besides maybe some fee-for-service de minimis payments for the visits. And in fact, that nephrologist is hurting him or herself financially by not performing all those dialysis treatments, right? So how do we design payment systems that can somehow reward the appropriate preference sensitivity of intensity is an open question. I think one of the models that we've heard kind of described in most detail, the condition-based payment model, as articulated by Drs. McClellan, Bozic, and Francois Debrance, gets to that to some extent, right? But essentially, I think of that condition-based payment model, the Musculoskeletal Institute as an example, as a subcapitated payment stream to a specialist for chronic longitudinal care, and all of the care that specialist provides comes out of that payment, right? So the way I think about it is not so much condition-based payments, but rather specialist-based payments, because I didn't hear this from Dr. Bozic, I should have asked, but let's say someone's in the Musculoskeletal Institute, you're getting subcap for it, and the orthopedist doesn't get paid more for performing elective joint replacement. But what if that same patient falls and has a fracture, right? Does that subcap payment cover that as well? I mean, there are all these other kind of details that I wish we had more time to dive into. Maybe those payments are more acute episode based and the bundle payments. But I don't know that this is a payment innovation for sure, but I don't know that needs to happen at the national level. I think just hearing Nikos's comment just now makes me think again that we should let these payment innovations occur more at the local level, and then ACOs, managed care organizations, can contract with organizations like the Musculoskeletal Institute. But at the national level, I don't know that we need to dictate that kind of care. Maybe we can have some pilot models to show its effectiveness. But I think if we just let the risk-bearing entity figure things out with the appropriate, counterbalances and protective measures, we should just kind of let them do that. I don't know that we can necessarily design a payment scheme that will help the frontline provider decide which are the high-value specialists in their locality. But I'm sure that that primary care provider probably knows, and so just give them the appropriate risk and reward framework and let them make that decision. So I was only kind of like half in jest when I was suggesting we already kind of have the basic framework we need. We just need to kind of maybe tweak it a bit and then get out of the way and let the frontline providers figure out how best to manage that risk.
Thank you, Walter. Lindsay, did you want to add anything? No? Okay. So we have covered a lot of ground today. If we went around the room, went around the table and said, what one thing did we not bring up? That one theme or one thought that wasn't covered that you would want to add? And Josh, would you start?
I think I only brought up one today, so maybe I'll just parrot myself and say I think the capability is really important. I didn't directly call it out, but Audrey's comments made me realize too that I think Jim mentioned time zero. I think at least for primary care, since the concept of medical home came about in the late 60s, I think that clock started at some point decades ago. So I think maybe the one thing I would highlight, and I mentioned this yesterday, is I don't think it's a cool app or just a change in the way we do a form and then we can all go on our merry way. I think if we really want to integrate, it's going to require a change in how we deliver care and operate organizations. And I think everybody has a role in that, but I think particularly potentially specialties or parts of care that are closer to time zero. I hope that's part of it. I hope that we don't just think about incentives and think about communication and think about technology. We think about how do we bring them along in culture, how do we bring them along capability to do that, because I don't think it's even across the healthcare community now.
Thank you, Josh. Jen?
I think it was said, but I'm going to amplify it. Data, data, data. We cannot move this conversation forward in a meaningful way and improve health outcomes for patients unless we have ubiquitous, that doesn't mean a lot, but important, actionable, transparent data to allow entities to become risk-bearing and for risk-bearing entities to deliver high-quality care. And that kind of infrastructure is expensive. And again, I think we need to encourage building off an infrastructure that we heard at our last meeting that's starting to exist, maybe through a RIO structure, maybe in partnership with our predominant EHR vendors. But that is a large hurdle and it's very potentially expensive. And those would be dollars that are well spent to do practice transformation.
Thank you, Jen. Angela?
So I was going to talk about data, but I'll go back and kind of reemphasize Josh's comments. I think education and training, and that's what I see missing in a lot of the practices. And when I say that, the basics of how risk works and what a health plan does to understand RAF coding, HCCs, all those things that frontline primary care practices often have little idea about, but it's so critical to their success. And there's really not a good resource for educating them and them able to learn quickly.
Walter.
So I guess I would just reemphasize my earlier comment about how to somehow reward specialists for preference-sensitive care that doesn't happen. Appropriately so.
And Lindsay?
Yeah, I think a closing reflection would be around when we think about high value care, and how we reward it. It's maybe not just in payment, but I think the other piece we need to figure out is how do we measure and value the communication and collaboration that go into that high value care, and who and where should that care coordination happen? Practice level, plan level, and I think the arguments were in favor of practice level, funded at the practice level, but that definition for what good looks like maybe is a gap to being able to evaluate.
Thank you, Lindsay. Jim.
My mind tends to think toward, as you already know, we probably migration from the triple aim to the quadruple aim, and that one of the things that we're really maybe want to spend some time thinking about as we kind of iterate is what we're suggesting going to actually improve the experience of being in the field as a profession, as opposed to, because what's not measured, an unmeasured event that's happening, is what happens when physicians are burned out. What are the sequelae in the way care is delivered, and then kind of what am I going to do next week, or how am I going to adopt the next model, or what technology I will or will not say yes to. How will I code? How will I document? How will I share, not share, is all driven by this kind of palpable burned out, discouraged, disappointed, somewhat almost defeated workforce. And that includes our nurses and APNs and doctors as well. So some of what we need to think through, is just making sure we have that filter at the end, kind of as we push everything through, is like, will this make it a better experience or not? And what may need to be added to do that? So adopting the quadruple aim.
Larry, I'm going to let you take us home, so I'm going to say mine and then let you close, because I know
you go ahead and do that.
So I'm just going to build on what Jim said. I think one of the most striking things, data points today, was from Kevin Bozick, where he said in 5 years they only had one person turnover from their team, and that's what I see nationally. These integrated teams, integrated models, interprofessional teams, different disciplines practicing to the top of their license, and really creatively looking at design and efficiency of how do we come together to meet the needs of the client holistically and in a way that makes sense, I think is critical. When we look at workforce shortages, we may have more workforce than we imagine by the creativity of how we deliver what we do. So I think that's really key and an opportunity in total cost of care models. Larry, it's up to you.
I think my parting words are, let's bring down the silos. It's time to break down the data silos, the provider silos, the contracting silos. We had a lot of knowledge, shared with us over the last couple of days, but I go back to Dr. Jones. He said, I get daily claims. Look what you can accomplish when you get data, when the silo is broken down. And I think that's my parting thought, is we've got to figure out how to break down the silos.
Thank you, Larry. So I think, are there any other comments before we close from any other members? Then I want to thank everyone for your very active and important participation today. Our expert presenters and panelists, my PTAC colleagues, and all those listening in and actively participating. We explored many different facets of improving care delivery, strengthening primary care, and integrating specialty care within population-based models. Special thanks to my colleagues on PTAC. This was a lot of information to take in these 2 days, and I appreciate your very active participation, thoughtfulness, and deep reflections about learnings from these 2 days. We will continue to gather information on our theme through a request for input on our topic. We're posting it on the ASPE PTAC website and sending it out through the PTAC listserv. You can offer your input on our questions by April 7, and we're very interested in your input. The committee will prepare a report to the Secretary with our findings and recommendations from this public meeting. And with that, the meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.